Hi, I'm Jack Cush, Executive Editor of RheumNow.com. I'm coming to you from ACR 2017 here in San Diego. We're on the exhibit floor and we're at the RheumNow booth, and I'm here with Pete Salzmann. Pete is Vice President of US Immunology at Eli Lilly and Company. I've asked Pete to come by so we could talk about what I think is a really interesting issue. So Pete, this issue in my mind, and it's come up with this new data about pain as a differentiator with a jackative that you're developing, baricitinib. And you know, when drugs are being developed, we as advisors and leaders in the community often are looking for distinguishing features, just as you are.
Yeah.
And we look at the safety data, we look at the efficacy data, we ask about costs, you know, and it ends up being yet another of a long list. So just recently, you know, there's this new data that's come up about pain as a differentiator, which is, I find surprising for this disease-modifying drug, baricitinib. So tell me the story behind it and how you think it's going to play out.
Yeah, thanks for the question. So first of all, the data that you're referring to is from our pivotal phase 3 trial, which compared baricitinib to adalimumab to placebo in CD-marred IR patients. So that was the population. And it had all the standard scales that you would think of, ACR scores, CDAI, all those kind of things, lab values. What we noticed as we looked at the components of the ACR was a differentially positive effect in pain, we thought. So Peter Taylor and others at Lilly conducted a post hoc analysis where they really tried to tease that out. And what we found is that compared to adalimumab and also compared to placebo, baricitinib resulted in a larger decrease in pain, and that decrease in pain happened faster. And interestingly, for those patients who had the most pain at baseline, they had the largest improvement.
So when you looked at those who had a pain response, was there anything about that group that was distinguishing compared to other patients? Did they have more inflammatory disease? Did they have more damage? Did they have more disability? Was there anything that distinguished them?
Yeah, great question. So the people who had higher pain at baseline, I already mentioned that, and certainly this was a group that was, you know, a pretty active disease if you look at the inclusion criteria. But you're right, among those people who had the most active inflammation, they also had the most pain and therefore the most pain relief. But among people who had their inflammatory signs improve, so just all the typical things as simple as swollen joints or CRP, we controlled, or Peter Taylor and his group controlled for that. And when you took out that which they called the sort of direct pain reduction, because you'd assume that if you reduce inflammation, you reduce pain, right? There was still this component that was unexplained. That was the indirect pain relief, and that part, that pain relief was pretty substantial. It was about 50% of the pain relief could not be explained by the improvement in inflammation.
So I would guess at Lilly, when you see these kind of results, you say, quick, let's look at our past data, let's look at dose-related effects on pain, and does this extrapolate to other studies? How does this play out by dose?
Yeah, so the differences by dose, so this particular study only had the 4 milligram, but you can look in other studies and you typically see that baricitinib relative to placebo in the other studies is going to show this impact. We haven't yet teased out the difference 2 milligram versus 4 milligram, but it's an important question, I agree.
Do you think this actually is going to tell you maybe this is a drug that will do something for pain and work in pain models, like dysmenorrhea, dental extraction, post-operative pain, whatever? Is that something that you want to look at this point, or right now it's still just a curiosity?
I would say it's neither a curiosity nor a broad-based pain development program. I think, you know, pain in RA is an important topic. I think you'd agree. And you know, during the Q&A after Peter's presentation, someone mentioned, you know, a rheumatologist mentioned, you know, we all have these patients who their swelling gets a lot better on exam, but they still have a fair amount of pain. And you know, that could be the type of patient who's really going to benefit from this differential impact to baricitinib. So we do plan to further explore how baricitinib can help patients with rheumatoid arthritis with pain, also psoriatic arthritis, because we're studying in psoriatic arthritis where you may have a similar situation.
So from a practitioner standpoint and one who represents a lot of rheumatologists, I can tell you that, you know, we do get frustrated when trying to find the distinguishing features and often wonder, is it even possible? So this is a novel finding, one that's encouraging, and I congratulate you for finding it. The question is going to be, how far can you take it? We're going to wait and see.
Yeah, absolutely. I agree, Jack.
Thank you.
Thank you.